Next speaker is nobody less than Ilse Degreef, who's going to talk us about Dupuytren's disease under the microscope.
Thank you, Jean. So, what do I do? Oh, ik kan er al op geduwd. Since I've heard a couple of times during this conference that surgery is a disaster, I think the last couple of years I focused on improving this situation and making disasters a little less disastrous. Disclosures, I did have an advisory board consultancy of FIDEA. I am incredibly motivated in Dupuytren research, and in a couple of years I'm granted some time by our national funding, FWO, and this is apparently also a disclosure, although you don't have any money. I'm also the founder and chair of the Dupuytren Fonds in Leuven. Also, it's just raising money to perform research. And I am completely obsessed by Dupuytren disease since over 20 years. This is my desk. It's terrible, I know. Here you can see the, is there a light on this? Yeah, okay. Here you can see the Lux knife. Thank you, Charlie. Where are you? Oh, right in front of me. I'm getting tired. It's a knife he gave me, developed by luck, of the staging, but he also cut Dupuytrens, apparently.
They made them in his machine shop.
In his machine shop it was made? Okay. It's still sharp, because I cut myself with it. Oh, okay. Yeah, the Peroni and so on. And now, oh. I'll be adding this because Anna, where are you? You made this. Anna is the chair of the Dupuytren Society, British one, and she made our Dupuytren Fund as an art. Thank you. So I'll find some place. So, but I'll do my talk. So the passion of, I don't fill it in, but it is a research roller coaster of terrible cases we all encounter. I focused on identifying these terrible cases before they come terrible, because there are a lot of these Dupuytren patients do not have a big problem in the long term, so let's not overtreat. We focused on disease control, pharmacotherapy and so on. Minimal invasive treatment, we don't want to hurt our patients too much. And in the end, now the last couple of years, I've been focusing on what I was raised to do, and that's operate. So we all are a part of the solution or the treatment of Dupuytren. And unfortunately, I'm a hand surgeon. So I focus now on how can I improve what I'm doing every day in my niche of helping these patients, and that's, I believe, by using the microscope, as we'll talk about. So we're pushing the boundaries, and by doing that, by using the microscope, we've also had new findings which I'd like to share with you. But the common thread in my research, and I think we all do this together, is being translational. That means translational. That means we go from bench to practice. Let's not just lock ourselves up in labs, but also go to the patient so that at least every generation has some improvement in clinical treatment. We've heard it before. The recurrence is the big problem. The recurrence is a challenge because the patient is dissatisfied. We are very unhappy, and we get these challenging cases where we do all kind of things like taking phalanxes out and stuff like that. So the research fund, when I got accepted, and that's in competition with oncology and stuff like that, which is life-threatening, so I was very happy that we can do this. It was named Dupuytren under the microscope. So I am focusing indeed on microsurgery, but also on the new findings and the new options that gave me, such as microbiopsies. So we can look at special features, have new findings, and look at new treatment options. And I focus on two things at the moment, and that's the skin and the nerves within the Dupuytren. And doing that, we try to introduce new treatment modalities. I won't explain the complete grant, but you can find it online. So on the one side, I aim to improve minimal invasive surgery or minimal invasive treatment by using adjuvants. In the past, I've used cellulose. Apparently, that's toilet paper. I was a little disappointed a couple of years after my PhD when I realized that sitting on the toilet and reading on the toilet paper 100% cellulose, I said, okay, I work with toilet paper. But anyhow, it worked. We used tamoxifen, and we used recently, Maarten published, we used NSAI, celecoxib in collagenase, that helps. And now we have finalized the pilot study, a randomized controlled trial with anti-TNF in fasciotomy. We are waiting for the results because it's blinded. And on the other hand, we improve the maximal invasive treatment or maximal invasive surgery by sharpening the indication, by identifying the patient that might need this, by looking at prognosis, by focusing on shared decision-making. The patient needs to steer his own treatment, and by looking at all these histological treatment features, such as we find a new micronerve anatomy that may be important to prevent and protect complications such as neuroma and neuroma-induced fibrosis, which may be the cause of recurrence anyhow, and how to, what does the skin involvement do? We use scutometry, we use histology, we use ultrasound to see what is the skin doing. And can a biopsy, for instance, or the measurement of the stiffness of the skin predict that this patient might need extra treatment, such as a full thickness graft as we've seen earlier? But let's go to the microfasciectomy history. It started with a Friday evening Dupuytren. What was a Friday evening Dupuytren? That were the ones that were difficult, and we put them at the end of the program when we were in Pellenberg those days. And usually it ended up with avascularity and the microscope and a lot of sadness. Now I realize why this is the case. Jean, you're not operating on smoking patients. I probably get all the smoking ones now.
That's right.
So,
correct.
Thank you for that. I didn't know. So the Friday evening Dupuytren. So then we had to undust the microscope because we used it whenever we needed it when it was too late, and start trying to salvage something that's probably unsalvageable, and 1 week later needed amputation anyhow. So at a certain point, I was kind of young at that moment. My mentor was still there. I defeated the judgmental remarks of using the microscope before the disaster occurred, because then my mentor would enter the operating theater. I was operating with a microscope. He said, "What went wrong? What's wrong?" Nothing. Nothing's wrong. I just want to prevent something from going wrong. What's she doing? But then, slowly but surely, I started improving the technique, because at those days it was like the team needed to go and get the microscopes, not used to it. We had to change from loops to microscopes. Sometimes you wait too long because you said, no, maybe I'll just manage anyhow with my loops. Those were challenging cases. Again, I'm not saying there were smokers or not, because it doesn't change my treatment, so I don't hardly ever ask it. But there were a lot of recurrent cases, and we all know how challenging those are. But by doing that, we also discovered new features, such as these micronerve anatomy, such as the skin retraction, where you see there is actually the myofibroblasts are present within the basal lamina, and so on. And that gave me some translational concepts, and especially project overload ideas. So I have a lot of projects going on. Now I just need to get them published. We know surgery in Dupuytren is dangerous. You have a lot of complications, but resurgery is very dangerous. And so we really don't want to do that. We want to prevent recurrence. But I see a lot of patients with recurrence. And now, these days, I can treat them again. Because by improving your visualization, by enlargement, and by being able to enlarge to the point you need it at the moment that you do need it, I have the experience and the impression that I have less complications and a better dissection. And also everyone is getting used to using this microscope, which is, as you all know, in hand surgery also beneficial in other domains. The future is also vision enhancement, where artificial intelligence will probably be used to even increase enlargement and sharpness and inclination of the scope and so on, for the whole team to have a 3D visualization of these anatomical structures. And sometimes I get poetical, and I thought, well, I must give this a name. So that's when the name microfasciectomy was born. I hope you forgive me. So it's simply microsurgery in Dupuytren, from step 1 to skin closure. I believe that the risk for complication decreases, nerve injuries, arterial damage, and that is necessary certainly in recurrent cases, but I started doing it in primary cases, in every case, as the colleagues in my department know. So the good thing is you have a visual enhancement that is better than in loop surgery. I don't understand why some people still operate without loops doing this, but it still happens apparently. And that's good. You don't injure anything. You don't see it anyhow, so you don't know you injured it. Structures under 1.5 millimeter are insufficiently visualized in loops, even with young eyes. And young eyes don't stay young. After 40, you get presbyopia. So for the ones who are macho, you will probably lose some sight anyhow. So it's my idea that it's better to prevent instead of treating complications. And then the question is, does it have an added value? Because it costs. Yeah, a microscope is expensive. Is it worth it? Does it benefit? It's better for your back, your ergonomy, probably even better if you can use an exoscope. And then I'm looking now at surgical efficiency and safety and how the microdissection can be done. So it was published here, if someone wants to read it, how you do it from A to Z during every procedure. So the patient is ready with a microscope on it when I start operating, and it's finished when the bandage is closed. So the full dissection is done completely under the microscope, as you see some images here, where you do see some structure. This is not a very big enlargement. Of course, I don't have an exoscope yet, so this is the image that is not as good as the surgeon himself or herself sees. I do the full dissection. You see the complete Dupuytren. I don't only go from proximal to distal. We see it completely, and not only the digital arteries and nerves are preserved, but also the micronerves and as much as possible, and the arterial branches. And that made us discover new microanatomy, which we are now publishing and was histologically confirmed. We are now looking into the role of these nerves that we didn't know before and that we are possibly damaging in loop surgery, certainly if you don't use your loops. This one doesn't have Dupuytren yet, I'm pretty sure. So even the Z-plasty is done under the loops. And that means that everyone is used to the microscope. Our residents are using the microscope all day long. So that's one of the big steps in replant surgery, using the microscope. So they are used to it, and that is a good way of getting used to it. So the sky is the limit. We'll see where we go. When I have a small arterial injury, I will repair it, even if it's not the main branch, even if I have a second artery left, because I think it's good to have more blood in your fingers. We do some subcutaneous exploration of the second ray and so on. We'll save that. So what's the outcome? I think here everyone's saying this takes too much time. Well, we've looked at the outcome. We have less complications, although we have more challenging cases. A recent study, and it's a poster over there, also confirmed that we have less recurrence. I didn't expect that, but apparently we have. and the revascularization after turning off the tourniquet is faster. Don't ask me why these fingers were blue. We just missed red dye at that point, back order. But the good thing is you could see the capillary refill here in the fifth finger, which was a very difficult PIP recurrent contracture, and it was quite fast. So if anyone has any idea how to measure this, it would be very interesting as a parameter to see how the manipulation of your vessels has been diminished by using the microscope and increases blood flow after releasing the tourniquet. Of course, if I start using Walland, that won't happen again. But the time increased 20%. And in the study over there in the poster, 60%. That's a lot. But I want to be relative. Time is not an issue for microfasciectomy because hands are worth it. I think you gain time in experience. After a while, the time loss isn't time increase. Yes, I'm finishing, John. The complications cost time too. And there's a study that mentioned that optimism reduces OR time by 20%, so that compensates. And recently, Esther Kahn is here. She has done a PhD in Dupuytren, is now currently our fellow. We started operating simultaneously with 2 surgeons. So you double speed, 2 fingers at the same time. So you can find all kinds of new things to compensate for that. The fact is, confidence through conditioning training, practice, practice, practice is the main key. Proficiency-based progression training is the next step in the program. And future innovations are enormous. We've heard it here, we've seen it, Walland, new techniques, new instruments, new microscopes. I'm sure that the next conference will bring more and new information also on this system, if it's still needed, if we haven't cured Dupuytren by then. But I believe using your microscope will benefit surgery in general. Thank you.
Thank you very much. Maybe just one short question, since it's been blinking for about 5 minutes.
Yes, but I did some blabbling and you were faster, so I took your 2 minutes.
Is there one question? I have just one comment about smoking. The advantage of asking them to stop to smoke is checking their motivation to undergo surgery. If you're motivated, you stop smoking.
Very good. We must do a study on that.